So today we have the two authors of the new book, Finding the Right Words, a story of literature, grief, and the brain. Cindy Weinstein is the professor of English at the California Institute of Technology. And in the book, she reflects on her late father, Jerry Weinstein's diagnosis of early onset Alzheimer's with the Logopenic variant. And Jerry passed away in 1997 at the age of 70. And Bruce Miller, who's a professor of neurology at the University of California, San Francisco, joins us. And in the book, he reflects on his own personal life as well as his own career. And he draws on his insights as a clinician and as a scientist to help us better understand the impacts of dementia. So thank you, the two of you, for joining us.
Thank you. We're honored to be with you today.
It's my pleasure.
Thank you.
So Cindy, I want to start the question with you. I wanted to ask you, what motivated you to join forces with Bruce to write and publish this book now? Because it's been quite some time since your dad was diagnosed with Alzheimer's, and quite some time from his passing. So yeah, can you tell us about what inspired you to write this book now?
Sure. I always wanted to write a book about my father and didn't quite know how to do it. What I did know is I didn't want to write the book alone, in large part because I felt like I had lived with the pain of his disease alone in a certain way. And even though as an English professor, I spent a lot of time alone writing books, this one was different. It was going to be different, and I knew it. And I was so lucky to find Bruce because he was able to, I had looked at some videos and some writing that he had done and knew that he could explain the neurology behind many of the symptoms of my father's illness in a way that a general audience would be able to understand. And that was really important to me. And one of the greatest challenges was figuring out how to get Bruce to agree to write the book with me. And also being able to try and recreate who my father was for Bruce. Because as you say, the events are very old. And my father died a long time ago. There were no MRIs or PETs available. So Bruce's knowledge of my father could only come from me and the stories I remembered about him before he was sick, while he was sick.
Right. And on your point about, you remembering the stories before your father, Jerry, was sick, right? In the book, you mentioned that it was difficult for you to actually recall those memories at the time when he was still healthy, right? Can you tell us about why was it difficult for you to recall those memories, and how did this book help you recall those memories?
I didn't know if this particular psychological fact was applicable to other people or not, or if it was just sort of my own craziness. But what I realized in the course of writing the book was that I had forgotten so much about my father before he got sick. I hadn't actually forgotten it, but I had hid it away so deeply and so carefully because it was too painful to remember him as a healthy person. I had had 25 years with him as a healthy person, but the disease was so overwhelming that it blocked from view all of these really happy, wonderful memories. And writing the book allowed me to, and I say this at the end of the, I guess at the end of the preface, it allowed me to grieve for my father in a way that I had been unable to for a very long time. And Bruce didn't know he was in on the grieving process so much, or maybe he did. Maybe he did. I bet he did. And it was only by sort of working out the grief and remembering the extremely painful things and looking at them very straightforwardly that then I was able to get to the happy stuff that happened before my father got sick.
Right. So in many ways, the book was like an avenue for you to embrace the grief that you had, embrace the grief and the pain that you've had for so long.
Right.
Right. And Bruce, yeah, sorry, go ahead.
I was just going to say, as sometimes happens when you write a book, you don't know what the thesis is. I didn't know that that's what I was doing until it was over and I had to write the preface. And I realized that what I had been doing with Bruce was, in the Jewish tradition, it's called sitting Shiva. And that's what I had been doing for a year in the way that maybe academics sit Shiva. So read a lot, study a lot, write a lot.
And Bruce, I want to take the question to you on Cindy's point. I was wondering, as a neurologist, as a clinician working with so many patients and families over the years, do you also see a similar pattern where it can be hard for family members and loved ones to remember, the good memories that they've had of their of the person with the disease before the person had the disease, to remember the memories when the person was still healthy? Do you think that's a common challenge for people?
It is. And I think the negatives of caregiving, even its effect on the health of the caregiver, can be so overwhelming that people forget who the person was, why they love them. And so I think this is very common. And, I think good clinicians spend a lot of time trying to get a sense of where someone is, but also encouraging them to, hear from me, and in my case, that they are doing an extraordinary job of looking after a very important special person. And that very important special person, even though they may have trouble with memory now, is putting out a Herculean effort to communicate, remember. And so I think for me, the validation is the first step in helping people to think about, the good times. And sometimes the degenerative disease is a good time. I think it varies enormously depending on the anatomy of the illness, the way caregiver and the patient have lived together. Many factors go into that. But I think trying to see the positive things is very much part of what I do.
Right. And the notion that people can still live well with dementia, right? I think that's a really important notion. And as you mentioned, right, there are still some good times, right, as people live with the disease, right?
Yeah, in Cindy's book, there's a very compelling, very sad piece about her father's friends who golfed with him until he started to have spatial troubles, and then they abandoned him pretty dramatically. And I, of course, this is not an admirable human trait. And if they were keeping track of their humanity, I think they might have realized that they had dropped. But I think the sadder part is that they lost the opportunity to become a better human being, and to change their own brain in a way that made it easier for them to help people the next time something like this happened.
Right. Yeah. Yeah, because Cindy, you like Bruce said, right? You wrote about the instance where like your dad has always loved golf, and you tried to get into it, but I think he he never got into it, right? But the thing was like his friends stopped playing golf with your dad at some point, right? And I think that was a chapter where you talk about living in two worlds, right? And on one hand, you know, you were in a really good place in your life, like you were studying at Berkeley as a graduate student, and you were very happy there. And on the other hand, your parents, your mom and your dad, were in a very different place. Can you tell us about, you know, how you contended with that of being in two different places, and what situation was like for your parents at the time?
I should say Bruce does a beautiful job of capturing the complexities of our relation to space in his response to my section on Lost in Space. To answer your question, how did I do? The harsh English professor critic in me says, like, terribly. I went into serious compartmentalization mode. And by day, I was happy English PhD student, loving Berkeley, reading everything I could get my hands on, becoming the best reader of literature I could be. And then I remember at night, the lights would go off and I would feel like I had an elephant on my chest. I didn't know what that was. I knew it didn't feel good. Anxiety wasn't such a term then compared to now, but I recognize it as that now. And so in the book, I talk about sort of having a really dangerous compartmentalization of life. And my parents were suffering inordinately. My mother was losing her social world. She was extremely social. My father, less so, but still his friends meant a lot to him and his golf partners meant a lot to him. So they were being abandoned. And it was also the 80s, and the science of Alzheimer's was not close to what it is now. And even maybe more to the point, how important caregiving is to the whole picture of dementia was not something anyone talked about. And I think that I knew my parents were suffering terribly, feeling abandoned, and a part of me thought that I had abandoned them too by staying in Berkeley. And yet I knew that my parents would never want me to give up on my dreams. And so I stayed and got the PhD. But it was really an impossible situation.
Right. And you wrote that, you know, in your 20s, irony really encapsulated your life, right? Can you
Right.
tell us a bit more about what you mean by that, Cindy?
So many, many versions of irony, becoming an expert in reading and literature and words while my father was losing words. That's probably the biggest irony, and that's really why I wanted and needed to write the book, because there was this terrible convergence of language acquisition and language loss. And I would almost read to compensate for my father's loss of language. And it was like a colander. And I would pour books in, but because it was a colander, the words would come out. So I would keep getting the words, but my father would keep losing them. So it was a race against losing words. And that's why I think the book is called Finding the Right Words. And it took me decades to get to UCSF and to get to Bruce and to get those words. And you mentioned the diagnosis that my father had in the 80s. It was Alzheimer's. Everything was Alzheimer's. And one of the most memorable moments for me at UCSF in 2018 was when Bruce said, "Cindy, this is what your father had. He had early onset Alzheimer's, which means he was younger than 65, with the Logopenic variant, which meant that the initial presentation was losing language."
And at the time, was he diagnosed with that particular variant back in?
Bruce, did neurologists even know about that at the time?
No, I would say hardly at all, even the best. I think Alzheimer's was a very homogeneous conception. It's memory, and all of the definitions required memory, often as the prominent symptom. And since around 2000, we've learned that many people, particularly with early age of onset, don't necessarily begin with a memory problem. They begin with trouble with language or with their spatial or executive skills. So I think we have a much richer and truer picture of what Alzheimer's disease is now than we could have ever imagined in the 1980s.
Right. And Bruce, I wanted to put a finer point and better understand what the logopenic variant of Alzheimer's is. Can you tell us, like, from a science point of view, like what's happening in the brain that's leading to the loss of language that's characteristic of this variant?
The term was first used by a language neurologist, Marilu Gorno-Tempini, here at UCSF, a real authority. And it was used to describe people who eventually we discovered, we didn't know at first, but eventually we learned that this group of people who begin with trouble finding words, trouble holding verbal information for very long. So often one or two words is all that they can understand at once. Often associated with trouble with reading and writing. This turned out to be one of the major subtypes of early onset Alzheimer's disease. So Marilu initially described the clinical features, and then as we started to do neuroimaging and ultimately pathology on our patients, we began to learn that this was a type of progressive language disorder that is not the frontotemporal dementia subtype that we had studied. So this was really a variant of Alzheimer's disease. It was unique. And then as this was studied further by Zach Miller, we realized that many of the people that got this form of Alzheimer's disease had been dyslexic in childhood. They had learning disabilities, as many as 50% of this population. And it's made us think in a very different way about when does a disease begin and what makes us vulnerable to one disease versus another. It's not that the dyslexia causes Alzheimer's, but if you are dyslexic and you get Alzheimer's disease, it may manifest initially in that vulnerable language circuit that you were brought into the world with.
And what's specifically happening in the brain? Like what brain regions are impacted in this variant of Alzheimer's?
Yeah, this is posterior temporal, near the area where we comprehend, Wernicke's area. And it is also posterior parietal. And that's an area that is very critical for reading and writing. So it's often a mixture of finding words, reading and writing all together, which gives us a hint that this is the beginnings of Alzheimer's disease.
And you mentioned that this variant is different than subtypes of frontotemporal dementia. How
Yes.
is this different than, how is this variant of Alzheimer's different than subtypes of FTD then?
Well, there are two other language for disorders. We call it primary progressive aphasia, where language is the prominent and early symptom of the illness. One, it's really trouble getting words out, and we call that non-fluent. And that almost always is associated with pathology associated with the tau protein, not amyloid like Alzheimer's, only tau. And then there's another type that hits the anterior temporal lobe on the left, and that is the semantic form, which usually starts off with trouble understanding what a word means, inability to understand a concept of something like an animal or a picture. And so even when you give the person the name of what they're looking at, it doesn't help them. So they really have this very unusual type of language disorder, and that's a different type of pathology. So the non-fluent and the semantic types have their own unique pathology that has nothing to do with Alzheimer's.
Right. So do you see like correlations of amyloid in the Alzheimer's variant of the Alzheimer's logopenic variant then?
So the story with amyloid and tau has been in Alzheimer's that amyloid comes first. It doesn't correlate very well with where in the brain someone is having a dysfunction. But where the tau is a very strong predictor of the clinical manifestation. So in this logopenic variant that Cindy's dad had, we see amyloid diffusely, but the tau in the posterior temporal and parietal region. So that's the best correlate of the clinical syndrome.
Right. Is the tau tangles that we're talking
Exactly.
about.
Exactly.
And Cindy, bring the question back to you. You know, as your dad was losing his language, and as you were studying as a graduate student at Berkeley, like even though you were physically, you know, apart, you were still communicating with your dad, right? Can you tell us about like the symptoms of his loss of language that you notice, even though you were physically distant?
Since we are talking so much about the particular variant that my father had, and when Bruce gave me that precision diagnosis, as it's called, I thought maybe I would just read a paragraph from the chapter in our book called Diagnosis, just to give the audience a flavor of the book, and then I'll talk a bit more about some of the other manifestations of the disease. As an English professor and the daughter of a father who had early onset Alzheimer's disease with the logopenic variant, I find this language of atrophy, aphasia, sulci, and logopenic variant at once powerful and weirdly comforting. I feel enriched by these words, partly because learning new words, even ones that translate into pain, makes me happy, and partly because they tell a story about my father that, looking back, might have been valuable to me at the time that he was ill. They exude accuracy and stability in contrast to the emotional quagmire of grief, love, and guilt with which I have been preoccupied for a very long time. It might have helped even just a little bit to have known that his losses had biological and chemical origins. So some of those other losses that you've asked me to talk about, they include a loss of conversation. I would call my parents in Florida, and my mom was always the more talkative one, but I was extremely close to my father, and our conversations were mostly me talking and him responding in a monosyllabic fashion. And then he would turn the phone over to my mother. So that was strange. Another manifestation was in the days of writing letters. My father's handwriting it was never very good to begin with, but it got significantly worse. He would type letters to me on his Selectric, his IBM Selectric, and there would be many more spelling errors than in the past, some of which he would catch, and there'd be an X, and then he would do the correct letter. Sometimes you didn't even notice that there were spelling mistakes. One of the biggest symptoms that I didn't know was a symptom, but learned from Bruce that it was, had to do with my father's mood. He was really quite depressed in the early 80s, and my family chalked it up to the fact that he was selling his business that he had been in with his brother-in-law for a really long time. Even though he was excited to be moving back to Florida, it was a huge transition moving from New Jersey to Florida. There were all these catalysts, in other words, that seemed to explain to us why my father was kind of a different person. And I remember going back to New Jersey with my boyfriend, now my husband, and Jim said to me, "Your father doesn't seem like the person you told me he was." And I said, "Well, he's depressed." And what Bruce explained in a very illuminating discussion of Parkinson's, he talked about how depression in dementia wasn't necessarily a response to the dementia, but was the disease itself. And the light bulb really went on for me when Bruce said that. And he was talking about Parkinson's. And I remember, Bruce, your exact term, you said it was a ferocious depression that often accompanied Parkinson's. And that was certainly the case for my father, even though he didn't have any symptoms of Parkinson's until well into the disease. So those were some of the things I noticed, Nicholas, about my dad.
So do you think your dad actually felt like depressed, that, you know, his language is going, that, you know, cognition is going, like that he's aware and that he obviously didn't feel good about it? Do you think that was the response to the symptoms?
It's difficult to speculate. I would say, yes, he on some level knew that he was losing himself. He was coming apart at the seams. But in the book, Bruce talks about, and I forget the word, Bruce, people who are experiencing dementia but don't know it, and what a gift that can be. What was the word, Bruce?
Anosognosia, denial or lack of awareness of an illness. And I would also say many times we see before someone even develops obvious manifestations of a neurodegenerative disease, a mood disorder. And I think we forget that things like mood and anxiety and psychosis all come out of the brain. And so if a disease hits a part of the brain that is involved with mood, then I think it's not unexpected to see somebody who is very depressed. Doesn't mean it isn't treatable, but I think sometimes the depression is even before someone is aware of their illness.
Right. So depression can actually be an early sign of some form of dementia.
Absolutely. And I take very seriously the new onset of a mood or an anxiety disorder or a psychosis in someone over the age of 50, because I think it's not uncommon that we eventually learn that they are on the road to a degenerative disease.
Right. And that can be tough for patients, right? Especially like during the process of getting a diagnosis and they have early onset, that like maybe doctors would think that they have depression but not dementia, and they go through a long process, a long diagnostic process, right? Is that is that quite common for patients to end up, seeing a psychiatrist and then not getting a dementia diagnosis for quite some time?
Far too long, particularly with all the new therapies we have. I think in our clinics, it's usually 2 or 3 years before someone gets to see us. We think of a therapy. Lots of things happen. Physicians don't ask. Family doesn't talk about it. Then sometimes they ask, but they don't test. A lot of times they do testing, but write off deficits and say, well, they were anxious or sad. Deficits on testing rarely are explained by that. And so it's a sad cycle of denial of this illness that leads people to get diagnosed much later than they should.
Right. And Cindy and Bruce, I wanted to talk about, the impact of how dementia impacts our relationship with our loved ones and our families. And Cindy, in the book, and I quote here, you wrote that, even if he, so you're referring to your dad, even if he didn't know exactly who I was, he knew I was someone who had mattered to him once upon a time. If someone remembers having loved you, is that the same as them loving you? Not exactly, but close enough. Cindy, can you tell us a bit more about, what do you mean by that?
I mean by that even with all of the assaults on my father's brain, he was always aware that I was a person who mattered. It didn't matter to me that that person's name was Cindy and he forgot that. It really was irrelevant. That was about ego. And that's why I say it was close enough. So obviously this is hard for me to talk about still. But I know that that section resonated a lot for Bruce. So I'm gonna do what any good professor does and hand it over to the other person in the room to pick up, if that's okay, Bruce.
Well,
Oh, you're on mute, Bruce.
yeah, sorry. We study caregivers. Our nurses are quite brilliant at this. Bob Levinson at Berkeley studies this with us. And I think we've learned that there's a ferocious burden on the family unit. Sometimes it manifests in actually causing physical illness. We think about 10% of caregivers develop a physical illness that they attribute to caregiving. A higher percentage, maybe up to 30%, develop some sort of a psychological disorder, sadness, anxiety, PTSD. There are a number of things that happen in the caregiving process. It's, I think, very hard on people it's hard on everyone. It's even harder on people without economic means to get help. So this year I interact a lot with people in South America from different communities there, and it was pretty clear that the burden on the low socioeconomic status peoples in Peru and Ecuador, it was unimaginably difficult. Here we often get respite care. We get people who can come into the home and help periodically. But I think not getting these sorts of things is, I always say this, is a real threat to the person who was caring for the patient with Alzheimer's.
Yeah, and a phrase that I've heard from patients living with dementia and caregivers is the notion of diagnose and adios, right? That they feel like they get the diagnosis and then they're left to their own, right? Bruce, do you have any thoughts about this? And, how can clinicians do a better job of really looking after the caregiver and making sure that they're okay?
Yeah. Well, the worst thing they can do is to join a chorus that blames them for things. I think a lot of times people in a family are criticized from different relatives. Well, you should have done this. This medicine works. I read about it, on the internet, even though it doesn't work at all. But so I think I always start when I see a couple, and it's almost always true. And I say, you two have done a really incredible job of dealing with a very tough illness. And then I look right at the caregiver and I say, and I think it's really important that we help you to maintain your health as well. And then we think with them about exercise. There's no doubt about it. Exercise is good for the brain. It protects from certain heart diseases, stroke, et cetera. So getting caregivers to look after their health is our responsibility. This is something I learned when I came to UCSF more around 1998, is that our responsibility is not just to the patient, but it's to that broader unit that is afflicted by these illnesses. And if we don't look after them, they get sick, and this adds to the burden. And we've even shown that it shortens the lifespan of the patient with the Alzheimer's disease, or in our studies, frontotemporal dementia.
Right. Because caregivers have to be able to take care of themselves in order to take care of their loved ones, right? So
well said. Absolutely.
And Cindy, since literature has been, so important to you, I was wondering, what types of literature, spoke to you the most while you're writing the book and while your dad had was living with Alzheimer's then?
So the book that makes the biggest appearance throughout Finding the Right Words is Moby Dick, which is a book I first read when I was 16 in high school, and I'm going to be 61 next month, and I have never recovered from Moby Dick, and I teach it whenever I can. In fact, I'm going to be teaching it this winter, so I'm really excited about that. And it's a book that has helped sort of take my emotional temperature. And I know that I'm doing well when I connect with Ishmael, who is a very funny guy and has a brilliant way with words, and gets seduced by Ahab for a little while, but then, not spoiler alert, but manages to survive at the end. And when I haven't been doing so well, emotionally speaking, I understand Ahab in a way that is not good, shall we say. And what I've also come to realize is the whale is a very important character in all of this. And he's probably the one wants to be most connected to, because the way Melville describes him is his eyes are on each side of his face. And so he's able to hold two completely disparate images, concepts in his brain at one time. And that's what I've tried to do in the book, be the whale. And so Moby Dick has been or texted throughout my life. And
about
while I was, go ahead.
Like, I was wondering, like, how do you think your understanding of the characters, like the whale and Ishmael and Ahab, like, how do you think your view of the characters have changed from the first time you read the book and then throughout your father's illness?
Yeah, that's a great question, Nicholas. One of the most sort of majestic things I think about how Ishmael Melville writes about the whale is trying to understand the whale, whether it's the whale's skin or the thing that comes out of the whale spout. And Ishmael has these chapters that set out asking a question: what is the skin of the whale made of? Or what's that stuff coming out of the whale spout? And in the course of trying to get to the answer, you get beautiful sentences and beautiful language, and you get to see a mind at work. And then you never find out what the answer is. And one of my favorite moments is in the part about the spout. Ishmael says, really, the only way you can figure out what's coming out of it is to stick your head in it and probably die as a result. And so you're just left with this sort of luxurious and amazing discussion and aesthetic and beautiful words. And it's all about the process of learning. And I think that at the process of learning and then the process of saying, you know, I just don't know, but it was so much fun trying to figure it out. And I think I wish I hadn't had to write this book, but Bruce helped me write it in such a way that it was really a beautiful process that I hope produced something really valuable and really beautiful.
Right. And on your point about the process of learning, right? I mean, obviously as a professor, you're a lifelong learner, but you wanted to learn more about neurology, right? And about the paragraph that you read to us earlier in this interview, you spoke about how terms like aphasia and sulci, things like that was oddly comforting in a way for you, right? And
Right.
was that the experience for you when you became a fellow at the Global Brain Health Institute, where Bruce is a co-director, right? You were a fellow there for a year. Like, why did you decide to study neurology? Was it to try to better understand, like, what was scientifically going on in your dad's brain and his body?
Well, Bruce said the magic words when I had met him a year and a half or so before the program, before the 2018-19 year began for me at UCSF, and he asked me if I wanted to learn some science. And I said, yes, how do I do that? And he said, you need to apply to the Global Brain Health Institute and come to UCSF, and you'll take classes and you'll sit in on grand rounds, and you'll get to talk to caregivers, and you'll learn about what neurologists do now. And I knew that's what I wanted to do. I didn't exactly know how it would all play out, but I was certain that the vocabulary that I had, whether it was vocabulary based in my love for my father or my love for literature, was inadequate to telling the story of my father that I wanted to tell. And so I wanted to find a neurologist who could write really well and could explain neurology to me, and I was a stand-in for the reader, in a way that a general audience could understand.
Right.
She was a great student of neurology. Yeah.
And Bruce, how about for you, your relationship with literature? How do you think has it been an important part of how you practice as a clinician or as a scientist or as a neurologist? How do you think it can help us better understand dementia and how it affects us?
Well, I in writing this book, I thought a lot about that, and this was one of the real gifts that I got from Cindy, is this ability to think about the role that books had played in my life, and I was very bookish. I read constantly throughout my young adulthood. It was probably the only unifying academic thing I could have said about my experience. And then after getting an English degree, I decided that I fell in love with biology and medicine and went back and got a chemistry degree. But I think the appreciation of literature and I realized writing this, when you read a book, you incorporate a whole new world into your own brain, and the richness of that experience, changing your brain forever. When I wrote about Cindy's dad, thought about how reading books with my grandfather, imbued me with a certain ethical point of view, a really strong interest in England, which he was interested in. And, these things stay in your brain for a long, long time and shape it and improve it. So, getting into this process of writing with Cindy, a brilliant writer. Oh, wow. It was just such a wonderful opportunity that doesn't come along very often. I just loved it.
Right. And yeah, I mean, literature and writing and stories, it's so important for us to learn about people's viewpoints, their values and their ethics, and how we can use those to apply it in our own lives, right? And it doesn't matter how advanced our technologies are. Like, at the end of the day, it's about the stories between people that we ground ourselves back in, right?
Exactly. And it's what a physician does, a good physician, is he learns people's stories. He listens, or she listens, hears where someone is coming from. And without those personal stories, we're quite inadequate, I think, in our ability to heal.
Right. To see the person and not just the disease, right?
Always start first with the person. Absolutely. Yeah.
Bruce, you mentioned that the highlight of your week is always seeing patients and taking their stories, right? That's always your highlight of the week.
It really is. It's every Friday afternoon, my clinic, and I think every clinic, every person I see, I learn something new, and I see it as a real opportunity.
Right. And yeah, I think to close things up here, to wrap up our discussion, Bruce, there's a paragraph in the book that I wanted to read, and I thought it was very impactful, and I wanted to read it to our audience, and see if you have any additional thoughts. You wrote that, nowadays there's a big push for more precise diagnosis with biomarkers, right? And so definitely very different from the time in the 80s when Cindy's dad had his Alzheimer's diagnosis.
Yes.
That, biomarkers, a term that's used to describe objective tests that can help with the diagnosis and staging of disease, should supplement, not replace, histories in our relationship with patients and families. We're social species. Technology will never fully supplant our need to connect, our need to tell and listen to stories, and to reflect upon the meaning of those stories. That is who we are. So, yeah, is there anything else you'd like to add to that?
Well, I think Cindy weaves quite a story in this book, and it forced me to think about my own experiences, the inadequacies of the language that we use in science. And the chapter on memory, I realized that when I tried to explain this, thinking about a lay audience who may not be study memory, I realized there were so many things we didn't understand, and I think it's an artist like Cindy that makes us understand the limitations of our own belief systems. And for me, this was quite profound.
And Cindy, my last question for you is, what do you hope people can take away from the book then?
I hope they can get information that will allow them to be better advocates for themselves and their loved ones when they interact with the medical and scientific community. That's one thing. And the other thing is that I hope people who are experiencing grief can know that, and Helen McDonald in this book called H is for Hawk talks about this, that there's no such thing as normal grief. That if it takes 30 years, it takes 30 years. And there's nothing you can do about that, you know? And that was pretty profound. I mean, I think I used to be, I don't know, ashamed. That's not quite the right word, but just thought there was something wrong with that. And now I don't advertise, although I guess I am advertising it a little bit, but that it's okay. And if you don't go through the various stages of grief the way the books tell you you're supposed to, that's all right. And being able to tell my story of broken grief and very long grief and deferred grief, it's my way of trying to help readers understand that whatever they're feeling, like, it's okay to feel it. You can't help it. So it's kind of a roadmap, a neurological roadmap that Bruce provides, as well as a human one. And he was a very good student, I have to say, of literature and writing, and also an emotional roadmap.
Right. And Bruce, is there anything else you'd like to add about the takeaways you hope readers can gain from the book?
What I'm very grateful to Cindy for writing a book where she learned the language to communicate about the brain. And I think there are lots of books from caregivers, but in this one, Cindy really went the extra mile to, integrate her own story with the real true biology of Alzheimer's disease. And so I hope people read it, aren't scared by the story, and are left with a sense of hope when they finish it, that we will do better than the previous generations did with Cindy's dad, and we'll do better 10 years from now than we're doing today. And the therapies are coming, and that's going to be a very different set of stories. What happens when someone returns from deficits, or whose deficits suddenly stop progressing? And that's the space we're in now. So there's going to be always a need for human stories about our science. Yeah.
Bruce, how do you offer hope for families without offering false hope at the same time as a practicing clinician then?
Yeah. I often, with most of these diseases, we're talking about slow. So I emphasize the good things that I can see, the wonderful humanity of the patient and their loved one, and the things that they do that bring joy to them and their grandchildren and others around them. I talk about exercise. I really do believe that this slows progression of illnesses and increases well-being. Emphasize social networks, stimulation. Emphasize that the average person with Alzheimer's disease who starts on a medication is about the type that are helpful, is about where they were after a year. So this is not necessarily, going to rob you instantaneously of all of the cognitive abilities. And in the meantime, there are new therapies coming fast. So I think it is a hopeful time.
Right. Well, thank you, the two of you, for joining us and speaking about your insights and your experiences. So
Thank you, Nicholas.
Thank you, Nicholas. Yeah.
bye.
Great.